I have slightly changed the topic of my talk because angina is such an important subject and so many patients suffer from it. It is really a combination and collaboration between family physicians and specialist physicians to ensure that the optimal medical care is provided to the patients. Diabetic patients, because of damage to nerve endings, they may not have angina, they may only have breathlessness. And this is described as ischemia equivalent. 1 in 5 patients may complain of indigestion on physical exertion. So the diagnostic challenge here is that the indigestion is related with physical exertion and not with the intake of food. Just to give you a scale of the problem, 1 in 10 people, in fact 1 in 9 males between the age of 55 and 74 have angina, and around 6% of females of that age group have angina. So if you put that in perspective to Pakistan's population, we are talking of millions and millions of patients. I hope this projects well. I'm really sorry it's quite small print. I'll just take you through this flow sheet. Patient presents with stable angina mostly to the family physician. Then the family physician starts the diagnostic workout by providing advice, a diagnostic paradigm, medications, and then medication for angina, medication for secondary prevention, and then decides whether this patient needs further investigation, further workup, or a specialist referral. Starting off from patient education, we must listen to the patient and establish the diagnosis. Every patient, every illness deserves a diagnosis. We explain the diagnosis to the patient and encourage the patient to ask questions. Encourage the patient to seek expert help if the condition worsens suddenly. We must understand that we are dealing with human beings at the end of the day. We must provide advice on medications, diet regulation, smoking, cessation, and risk factor modification. This is just the initial ladder of the diagnostic workup. Managing stable angina itself has 3 important steps: medication, investigation, and the goal for revascularization. I've used the word revascularization because this may be angioplasty or this may be bypass surgery, depending on the lesions. Medical therapy, optimal medical therapy consists of 1 or 2 anti-anginal medication on the maximal tolerable dose. Beta blockers and calcium channel blockers are first line choice. I've provided a list of beta blockers on the left side and calcium channel blockers on the right side. This definition of OMT is taken from NICE document and also from the European Society of Cardiology guidelines. A word of caution that we should avoid combinations of either verapamil or diltiazem with beta blockers because the patients may develop heart block. So if you want to use a calcium channel blocker with a beta blocker, I would suggest use amlodipine, nifedipine, or similar drugs. Second line anti-anginal agents include long-acting nitrate, isosarbide mononitrate, for example, ivabradine, I think it is available in Pakistan in the name of Ivatab, nicorandil, and ranolazine. These are second-line anti-anginal agents. I've seen a drug called tributazidine being used, and that is not actually mentioned in any of the guidelines as an anti-anginal agent. For secondary prevention, we include aspirin, cholesterol-lowering tablets, statin, ACE inhibitors, or angiotensin receptor blockers, depending on if the patient has a history of hypertension or whether there is an LV impairment on the echocardiogram. This is the initial medical therapy that is initiated by the family physician, which includes education, risk factor modification, primary prevention, and secondary prevention. Then we move on to investigation. This is probably the stage where a family physician will collaborate with a specialist physician. There are 3 groups of patient population, and the test we use depends on the probability of the presence of coronary disease. Low probability group, in which there is a less than 30% probability of coronary disease, then you have the intermediate group and a high probability group, and I will elaborate on those. For the low probability group, CT coronary angiogram is an excellent test. For the intermediate probability group, stress tests, which include a nucleus scan, a stress echo, cardiac stress MRI, which I don't think is available in Lahore at present. I may be wrong. And for high probability group, coronary angiogram is the investigation of choice. A word about exercise tolerance tests. You would have noted that I have omitted it. It is still being used. However, according to recent guidelines, an exercise tolerance test has no role in ruling out underlying coronary disease. It has poor sensitivity and specificity. It is falsely positive in 1 in 2 people. So if we have lady members here, if I ask them to all perform an exercise tolerance test, regardless whether they have coronary disease or not, their treatment will be positive in 50% cases. That explains to you how poor a test, exercise tolerance test is, and it has been phased out in the Western world completely from the diagnostic world. This chart I've taken from the NICE guidelines, and it just elaborates on the high probability, low probability. And I'm very happy to email this to anybody who's interested, but you can also get it from the NICE website. You can have it under your table. And this gives you a quick guideline on how to investigate your patient. Patients who have non-angina chest pain, patient says, oh, I just pain here, 1 point, tender, worse when I take a deep breath, that is not angina. And then you look at the age group of the patient and see if the patient has any risk factors. For example, high risk include, I don't think you can see it, but high risk on the bottom side includes diabetes, smoking, or a history of elevated cholesterol. And according to that, mostly patients in this group will either require a CT test or a stress test, like a thallium scan. If we move on to the next patient's atypical angina, for example, somebody says, I have indigestion when I walk, or I have breathlessness when I walk, not classical angina. Again, we look at the age and the probability of underlying coronary disease, high or low, and you investigate accordingly. And I hope you will notice that any male above the age of 45 automatically falls into the group requiring a coronary angiogram to rule out underlying coronary disease. If we move on to a typical angina patient, which is around 65 to 70% of patients which present with angina, all males require a coronary angiogram regardless of their age, and most of the females in high risk group also require an angiogram to rule out underlying coronary disease. This is where a coronary angiogram is very important. Say, for example, you see a 45-year-old woman in clinic who has diabetes and says, doctor, I get angina when I walk, I go to the washroom, I get breathless, I get a bit of boj padta hai. That is angina. That patient should be referred for an angiogram. That was the initial management, which includes medical therapy, risk factor modification, discussion with patients, and introduction of medications. Now comes the goal of revascularization. Where do we move on? Do we just leave the patient on tablets? We don't investigate. If we investigate, what do we do from there? And I think it is important for family physicians to understand what happens in the hospitals. I'm sure a lot of you go to hospitals, you have patients in hospitals, but some of you may not visit hospitals. And I think it is important to integrate and collaborate and understand from our perspective, from cardiology perspective, what we do day in, day out. Indication for revascularization stable angina include greater than 10% of myocardium being at risk, or failed medical therapy affecting the quality of life of the patient. आपने patient को 2 tablets डाल दिए, patient को उसके बावजूद angina हो रहा है, quality of life affect हो रही है, आप उसे refer करते हैं angiogram के लिए, angiogram होती है, और वहाँ पे हमें पता चलता है कि there is a diagnosis या there is 3 vessel disease, उसके हिसाब से we act accordingly, बताएंगे कि bypass होगा या stent is good. The 10% myocardium is taken from the study which was published 6-7 years ago. It's a very big study, thousands of patients. And all I want you to look at is the lowest line on the graph. Patients who had 10% or more myocardium at risk, they had worse outcome on medical therapy alone. In other words, such patients need revascularization. They need either stents or bypass they need a definitive treatment. They cannot be left alone on tablets. However, patients who had very low myocardium at risk, they did very well for a number of years. This is just to explain to you some diagnostic power of our tests. And more or less, CT angio, stress echo, nuclear, and MRI, they have similar diagnostic power. A diagnostic coronary angiogram is a gold standard test. It has high diagnostic accuracy. It requires high level of training and expertise and resources. It can be used to make a physiological assessment of coronary lesions. The cardiac catheter lab in the 21st century is a very exciting place. We can make physiological assessment of lesions at the same time, and I will explain to you shortly. And has the potential role to be converted into a therapeutic role. For example, if patient needs angioplasty, then you can carry on because you have everything there, and you can move on and treat the patient. This is just a figure to show the right coronary artery and the left coronary artery, how they appear on a diagnostic coronary angiogram. For example, this patient I saw in clinic last week, 50-year-old male, hypertensive, classical history of angina, loaded with aspirin critical, came for an angio during the seed. There was a tight stenosis in the mid-LAD, one drug stent, went home the next day. Is it that straightforward? Can we just look at the lesion and say, yes, we need to stent, move on? It is not. And physiological assessment has a definitive role. For example, this patient, there is a lesion in the left circumflex which is shown with a white arrow. Should we stent it? Should we leave it? What should we do? It's not that severe. And in such patients, we use a pressurized system to assess the lesion, the hemodynamics of the lesion, whether it is flow limiting or not. Lesion to है हमें नजर तो आ रही है, मगर उसकी वजह से blood flow कम है या blood flow normal है. It is a wire like any other coronary wire which is advanced into the lesion, as you can see in the cartoon. It is being advanced across the lesion. And on the right side, you can see a console which gives us the readings. We gave patient adenosine to induce hyperemia, and this diagram is, essentially shows on the, if I have them, sorry. This is a normal artery, and here is the stenosis. This is the PA pressure before the stenosis. This is the distal pressure. D means for distal. And we can measure the gradient across the stenosis by giving hyperemia, which is through adenosine. And if the value is abnormal, then we know that this lesion is flow limiting and we must treat it. We must revascularize. Same elaboration, another example, this lesion, you give adenosine to the ratio of PD, which is the distal to the lesion, and this is the proximal to the lesion, and that will give you a gradient. Normal value is anything above 0.8. If there's anything above 0.8, we do not require revascularization. Anything below 0.8 is abnormal, and that means definitive treatment. This is the case of a 67-year-old woman who had classical angina, atypical chest pain by CCS class 2 angina. She had a normal stress EGD. She had an equivocal exercise stress echo. She had a normal nuclear scan. She had a normal CT coronary angiogram. But there is a lesion in the left main ostium. She had a pressure wire assessment, and that pressure wire FFR was 0.61. I've just explained 0.8 or above is normal. This suggests that this is hemodynamically flow limiting and needs treatment. So it just gives you the diagnostic power of this test in comparison to other tests. This FFR is the gold standard test, physiological assessment of coronary lesions. This is another case, a 69-year-old male, 3-vessel coronary disease. On a nuclear scan, the only area that was ischemic was the circumflex territory. The right coronary artery has a tight stenosis, the circumflex has a tight stenosis, the LAD has a normal segment of stenosis. Pressure wire of the right coronary, 0.43, abnormal. Pressure wire of circumflex, 0.32, abnormal. Pressure wire of LAD, 0.67, abnormal. Patient went on to have bypass, 3-vessel coronary disease. Nuclear scan had only picked up 1 lesion. I was involved in this work because we were answering the question whether patients who have an angiogram, should they all have pressure wire testing, or should the decision be made on the angiogram alone? And what we found was that if patient had, at the level of an angiogram, a pressure wire assessment, then in 25% patients, the management plan changed. What it means is कि अगर हम एक चौथाई पेशेंट को कहते थे 100 में से एक चौथाई कि इनको टैबलेट छोड़ दें, इनको बाईपास करा दें, इनको स्टेंट डाल दें, एक चौथाई का प्लान चेंज हो जाता था अगर हम उनका उसी वक्त प्रेशर वायर असेसमेंट करते थे. That is a very, very big change. This was published last year. And this is a very important study. I'll just quickly go through this. It again explains the power of pressure wire assessment. This was published 2-3 years ago. Very big study. And essentially what they did was they had around 900 patients. They had a pressure wire assessment of the patient's stable angina, coronary lesion which was angiographically severe. They pressure wired it and decided whether they should be managed medically or they should be revascularized, either bypass or stents. And the patients were followed up. They published 2-year follow-up, but they are being followed up for up to 5 years. And what they found was the patients who had ischemic lesion on medical therapy, they did very badly. And in fact, if they had intervention stents in ischemic lesions alone, then the risk of death, myocardial infarction, or urgent revascularization was reduced by around 70%. And that's just 12 months, 1 year. In fact, if we look at just angina status, even that was significantly reduced at 30 days, 6 months, and up to 12 months. The orange bars are patients with angina on medical therapy. The blue ones are patients who had intervention stents. आप देख सकते हैं कि डिफरेंस बहुत ज़्यादा है. यहाँ पे 60% reduction है, 54% reduction है, 85% reduction. In summary, stable angina is a common medical condition. Optimal medical therapy has an established role in controlling symptoms. In patients with high probability of coronary disease, coronary angiography is the investigation of choice. Pressure wire assessment of a coronary stenosis is the gold standard test. Revascularization has a definitive role in improving symptoms and improving survival in patients with 10 or more % ischemic myocardium at risk. Thank you very much for listening.